Hello, ladies and gentlemen. Thank you very much for joining us. My name is Sanjeev Narayan. I'm an associate editor of the Journal of the American College of Cardiology, and today with me we have Dr. Rohit Mehta, who's going to be discussing his new paper, which is coming up in a forthcoming issue, entitled Device Interactions in Patients with Advanced Cardiomyopathy. We have Dr. Mehta here to discuss that. Hello, how are you? So, Dr. Mehta, we found your paper very interesting, and in it you describe a potentially very important clinical interaction between two different types of device in patients with advanced heart failure. Could you tell us a bit about your findings?
Sure. We actually had a patient who had an advanced cardiomyopathy and developed cardiogenic shock, and at the time she had an implantable defibrillator in place. To go to the operating room, we turned her detections off, and then she had a left ventricular assist device placed, but following implantation of the LVAD, we were unable to communicate with her device again. Thus, her detections remained off, and she was potentially excluded from a vital life-saving therapy. At the time, it was concerning to us because there was a big move in the industry to move towards wireless technology, both from the standpoint of patient convenience as well as a number of clinical issues that are of benefit. And so we took it upon ourselves to really try to facilitate the nature of the interaction, because we felt it was something that it would only get worse in time with the different applications that were coming out.
So basically you had a patient who already had an indicated ICD. Mm-hmm. The patient's clinical status got worse. An left ventricular assist device, I believe it was the HeartMate 2, was implanted.
That's correct.
And then you could no longer communicate with the ICD.
Correct.
And I believe you had another patient in that study with a similar story.
We did. Actually, there was another case that arose after we initially began writing the case up. And it was a similar situation, a patient that had presented to our institution with an LED infarct, who was about 8 hours to 10 hours out from their infarction and had completed at that point in time. She had developed a pretty bad cardiomyopathy and advanced congestive heart failure, had an ICD placed for primary prevention of sudden cardiac death, and in a similar fashion developed cardiogenic shock that necessitated a left ventricular assist device. In a similar situation, went to the operating room with therapies off, and then following implantation of the LVAD, we were unable to communicate with her device as well.
Gosh, so that could be a very serious situation with therapies off. So what did you do next? I believe you were unable to program around this.
We were. We attempted to actually instill barriers between the two devices. We attempted to alter the VAD flows to change the frequencies at which the left ventricular assist device was operating, but unfortunately we were unable to restore therapies. Then we proceeded to actually change out the pulse generator. And what we did was prospectively, with the help of our device reps locally, they provided us a device to test on the field. And so we pulled the device out of the pocket, and what we found is that immediately pulling the device away from the ventricular assist device restored communications outside the pocket. We proceeded to then put a new device on the field, test it outside and then again inside the pocket, found that everything was working sufficiently, performed defibrillation thresholds again, and then finished the procedure. We did send the original device back to the manufacturer to make sure that there wasn't just a sporadic engineering flaw, and the device came back functional.
Super. So the full details of what you think the interaction was are in your manuscript, which I think is outlined very well. But could you briefly describe whether you think it was the motor frequency or the telemetry frequency? What do you think was the culprit?
Well, what we found in talking with the various technical support teams, the Thoratec HeartMate 2 actually has a 12-volt battery that supplies power to both the controller for the device as well as to the motor. And what we found is that in order to reduce the voltage to the motor, they have to utilize what they call a pulse width modulator. And that pulse width modulator is continuously on, so it operates in a wireless telemetric fashion all the time. It never turns off. And it operates at a frequency of about 7.2 kilohertz, which is very close in nature to the telemetry frequency of the implantable defibrillator that both the patients had.
I see.
And that was about 8 kilohertz.
So this was not related to the rotational frequency of the device. Presumably it was spatial, and so could you have potentially got around that by moving the power supply further away, or theoretically could this be circumvented by having a right-sided implant, or would that not be far enough away?
Well, interestingly enough, the first patient actually did have a right-sided implant.
I see.
But your point is very good in the fact that there are a number of anecdotes out there, and a few that have actually come into publication of methods to actually increase the distance between the two controllers. And in fact, one center actually used cast iron cookware as a shield between the two devices and was able to restore telemetry. We attempted that, but unfortunately in our patient's case, this wasn't successful.
So you don't routinely prescribe that?
Not routinely.
Well, Dr. Mesa, thank you very much. It was a very thought-provoking article, and I'm sure our readers will enjoy reading that. Thank you very much.
Thank you.